All right. So I'll be taking us through optic nerve assessment. And as an introduction, this is a very important topic because glaucoma is a leading cause of irreversible blindness worldwide. And unfair as it is, Blacks are disproportionately affected. Blacks and Asians. So Blacks are 3 to 4 times more likely to have glaucoma. And not only that, the onset is much earlier. In the Western population, they say about 60 is when the risk factor for glaucoma begins. But for Blacks, even at 40, our risk factor begins. And then we have greater severity in terms of glaucoma. Personally, I hardly ever catch a patient with mild or moderate glaucoma. It is usually one eye is blind and the other one is on its way. So greater severity even at diagnosis, and then faster progression, much more aggressive. And even with the best care, we tend to have poorer visual outcomes, which is very, very unfortunate. So very, very important that we who serve Blacks day in, day out, be very keen to screen all patients who we come across, even in the best settings. This is a patient who is good with follow-up, patient who has the best care, gets good IOP control. Okay, we're talking about pressures less than 10. 10 to 30% of these patients will still go to the grave blind. We were talking with Dr. Nantasaba a few weeks ago, and she reminded me that glaucoma management is slowing the progression, not stopping the progression. So the progression still happens in quite a number of patients, and I have 1 or 2 patients who are very well controlled on treatment or post-op, but they are still progressing. Their vision was 612 at some point, but that was a tunnel vision of 612. And eventually that goes as well. And it is very sad and very difficult to explain. They're still putting medication, their IOPs are well controlled, but they still end up going blind. So 10 to 30%, even in the best of care, even in the best of facilities, still go blind. And this is even worse in Blacks. So today we're going to look at steps in glaucoma evaluation, just as a reminder. Number 1, very important, history taking. Past ocular history. Have they had surgery before? I don't know why it is that some patients do not want to disclose that they've had surgery elsewhere, they've been on follow-up elsewhere, they've been on medication elsewhere. For patients with allergies, very, very important that we know what kind of medication that they use. This is particularly when it comes to Probeta-N, which works very well and very quickly for these patients, tend to self-medicate long-term. So past ocular history, very, very important. Family history. Family history, positive family history of glaucoma, particularly in first-degree relatives, carries a greater risk of having glaucoma in such patients. So family history, very, very important. If they don't know, they're not sure why their grandmother went blind, why their mom keeps going to the hospital, it is important that they go and ask and come and confirm. History of steroid use, not only in the eye drops, but also taking orally. I have a patient who has severe allergies, asthma, and he's a ranger. So he goes out at night to watch out for poachers.
Yeah, there is an ophthalmology one, so I want to log into the other one on my laptop.
So this particular patient would come and the pressures would be in the 50s one time, and then another time the pressures are 14, 15. And it was very baffling because the discs were looking very good, which told me that these 50s are not constant. He's not always at IOPs of 50. So digging a bit further, he said he always has prednisolone on him. So anytime he goes out to do a night watch, he gets an asthmatic attack, or even to prevent an asthmatic attack, he pops the prednisolone pills. So once we moved from prednisolone to montelukast, he's been very stable since, and thank God he didn't have any nerve damage. So very important history of steroid use. I have a number of patients who have cancer, and they're also put on steroids. So of course, we're not going to stop the steroids in this case. We are just going to have to manage and put them on anti-glaucoma medications to lower the pressures to prevent nerve damage. History of drug allergies. Some of our medications have sulfur in them, timolol. The patients who are sensitive to timolol, depending on cardiac condition that they have. So very important, take a history of drug allergies, past medical history, as I said, asthma, but other cancers as well, and taking history of what medications they are on. They may not know that it's a steroid. So often I will Google in the consultation room to just confirm whether or not what you are mentioning has steroid in it. History of trauma, very, very important as well, and kind of informs what you're looking for and what to expect. Speaking of which, I have a patient who was 21 years old and had a huge trauma. And so the disc, whatever we're seeing in the disc, was suspicious, but with normal IOPs, and therefore balancing, is this a traumatic neuritis or is this a glaucomatous change? Is it progressing, or do we just monitor it? Was it a one-off? Is it a burnt out glaucoma? So after history taking, examination is very important. We need to look for signs and symptoms of previous surgery or laser. As I said, sometimes patients are reluctant to share this information, or they just forget. They forget. We need to look at the AC depth, the depth of the anterior chamber, very important in determining whether or not we have open angle glaucoma or angle closure glaucoma. And that also dictates our next steps. Rubiosis, very, very important. I work in a center where we have a very robust VR unit, and I see quite a bit of this. So rubiosis is very, very important. Sometimes you might miss it, and therefore I advise strongly that if a patient is diabetic or has PDR, you look at the iris on high magnification, times 16 or times 25, times 10, sometimes you might miss early rubiosis. RAPD, that's pupillary reactions. Very often my patients have advanced glaucoma in both eyes, so it's just sluggish reaction in both eyes. So sometimes RAPD is for the books. The lens, very important to examine the lens. Is it the one that is it a swollen lens that is causing angle closure and needs to come out? Is there exfoliative material on the anterior lens capsule? Very, very important, and a very common cause of unilateral glaucoma. Goldman applanation tonometry, very, very important. Or eye care, in case you don't have the applanation tonometer. The eye care is very close in approximating the Goldman tonometer. So for how often we prescribe steroids, because Africans have more allergies and more aggressive allergies than we find in the West. We prescribe steroids a lot, and rightfully so. But because we do, it is only prudent that we also have ways of measuring the IOP of these patients on whom we are using steroids long term. So we are giving injections of steroids. We are giving eye drops long term, steroid eye drops. Very, very important that we monitor these patients in terms of their IOP. Eye care is a very good one, so I advocate for all eye clinics to have an eye care, or at the very least to do applanation. Gonioscopy, if you can, would be a good thing to also do as part of the examination. Dilated fundoscopy. Dilated fundoscopy is very important. There are things that we don't see when we look at the disc through a myotic pupil. We also miss pseudoexfoliation on the anterior lens capsule. So very, very important that if you suspect this patient has glaucoma, a dilated fundoscopy for disc assessment. Further to that, investigations that are very, very necessary, CCT. Sometimes you have thick central corneal thicknesses that tell you a pressure IOP of 24, 25, you can monitor, or very thin corneas that make you conclude that IOP of 18 is actually in reality IOP of 24. So central corneal thickness, very, very important. There's a conversion table for the different corneal thicknesses available online. OCT, as a rule, I do CCT, OCT, and HVF at initial assessment. Why? Because there are patients who have come with hemianopia, and we are looking at this as a patient with glaucoma. Yes, the IOPs, one patient who had very high IOPs, yes, they were glaucomatous, but the HVF showed a very clear midline shift. On MRI, a hemianopia. On MRI, this patient had a huge, huge tumor. And meningiomas, because they grow slowly and they are benign, they are not as aggressive as the more cancerous lesions. So nowadays, and because the disc can be a bit deceptive, I do OCT and HVF as a baseline, and then determine going forward which modality we will use, either one or both for follow-up. So back to our topic for the day, which is disc assessment. There are two very, very interesting protocols that I found online that were very useful in how to go about disc assessment. Very, very friendly. The GONE project was of more interest to me because they have a website and it is free, and they have so many pictures, lovely explanations, and they actually allow you to test what you have learned, and they grade you and allow you to retake the test so that you keep learning. Very, very interesting, free website available, GONE project. So GONE stands for Glaucoma Optic Nerve Evaluation. This was developed by Australians in about 2008. They put up the website. It is free. I really like it. They have the 4-3-2-1 rule. 4 things on the outside. I admit I always rush to look at the cup disc ratio, but 4 things on the outside to look out for, 3 things on the inside of the disc, 2 confirmatory features, and then lastly, everything tied together to give you an idea of whether or not this patient is a glaucoma patient. Another one that is also available is called FORGE, F-O-R-G-E, Focusing Ophthalmology or Reframing Glaucoma Evaluation, mouthful. They actually look at the same thing, but they phrase it as the rule of R's. So you actually end up looking at the same thing, the ring, the rim, that's the rim of the cup, then the disc, I'm sorry, the CDR, the RNFL, the parapapillary atrophy, and retinal hemorrhages. All these are covered in both protocols. So I'll go through the GONE project. That is my preference, but both are very, very interesting. But Ford doesn't have a website, GONE project does. So 4 things on the outside. 1, parapapillary atrophy. Parapapillary atrophy is tricky because it can occur in patients with high myopia. Very important because it blurs the disc margins and causes enlargement of the blind spot. So very tricky even on visual field. It's kind of distorts your visual field and distorts the rim where the margins of the rim are. So very important that we have a look and a good look at where the parapapillary atrophy is and where the rim is. For example, in our first picture here, you can see all this is parapapillary atrophy. The actual disc is that tiny ovoid shape right at the center, right? So if you're not careful, and we look at this through a myotic pupil, it's very easy to say that is the disc, right? So very important that we have a good look. So this is probably a patient with high myopia because that disc looks a bit small, not much of cupping there. Disc size, as I mentioned, also very, very important. Why? We tend to have very large discs as blacks, large discs. And large discs, on the one hand, we tend to overestimate glaucoma in large discs. Large discs come with large cups and they tend to be deep. On the other hand, the disc size, when it is small, we tend to underestimate or underdiagnose glaucoma in patients with small disc size. These patients with the small disc size usually have high myopia, which is another risk factor for glaucoma. And we underestimate a CDR of 0.7 or 0.8 because already the disc is very small. So we overestimate glaucoma in a large disc and in large discs, and we underdiagnose glaucoma in small discs. What's a normal disc size? The small disc size, less than 1.5 millimeters, large, above 2.2 millimeters. How do we measure this? Depends on the kind of lens you have. So if you're using a 60, diopter lens, then your conversion. So when you're looking at the disc using your lens and the beam, you slit the beam and reduce the size of the beam until it is against a vertically this from the tip of your disc and up and down, both up and down. So that is your beam. Whatever you get, the measurement, you multiply by the factor depending on the kind of lens that you have. So a 60 diopter lens, you don't need, there's no conversion factor. It's 1.0. If you're using a 78, it's 1.1. If you're using a 90 diopter lens, it's 1.3. So that gives you that conversion rate multiplied by the number, the length of the beam when you put that beam against the disc will give you the size of the disc. So less than 1.5, that's a small disc. Above 2.2, that's a large disc. Another thing for those who use direct ophthalmoscopes, the one that we have usually has three size beams. So the central beam, the one at the middle, when you're going through your ophthalmoscope, you have a small beam, you have a medium beam, and then you have a large beam. The medium beam, when you're focusing on the disc, if you're able to focus on the disc, it should fall right at the disc. It's about the size of the disc when you're using your indirect. So maybe if you're out in the field doing outreach and you're using your direct ophthalmoscope, the central beam should be about the size of the disc, and that can kind of give you an idea whether or not you're dealing with a small disc or a large disc. So that's for the disc size. So we need to be very careful when we are dealing with the small discs and with the large discs. So disc shape, also very important. As we can see here, the shape of the disc is ovoid and it is tilted. This is important in two ways. One, you cannot really tell about the cupping in this patient. It's very difficult to tell whether or not there is a focal rim defect. More importantly, where the disc, the parapupillary atrophy can easily give a hemifield defect. And then this is a patient who is a high myope. So very, very complicated case, but very important to note that this patient could easily have glaucoma, and probably best to follow up very, very closely if they don't have the overt IOPs of 30s. So that is a small disc for us, less than 1.5, 1.9 just within normal, and a large disc of 2.4. So we've looked at the outside of the disc. Now let's look at what is inside the disc. The cup depth, kind of already talked about it, that large discs tend to have big cups, and a deep cup can be a normal variation. We've seen physiological cupping look very, very scary, especially in large discs. So that can be a normal variation. It can be hereditary. So let's not use deep cups as the sole, in fact, it's not the most important way of determining whether or not there's disc pathology. So cup disc, the depth can actually reverse in patients who have had congenital glaucoma and the patient underwent intervention. They actually can reverse the cupping. It becomes shallow. Yeah, so that can happen. And I found patients who had surgery in childhood, and when you look at the disc, they actually look nice and healthy. So reversal is actually possible, which was an interesting concept for me. Small tilted disc can hide cupping. Very important to note when you're dealing with small cups. What is important is looking at the CDR. Determination of the CDR is the most important way of determining whether or not there is disc pathology. So let's look at that. So in this first, here in my panel, the first CDR, we have the cup about 2 to 3. There's a study that showed discrepancy even between glaucoma specialists can vary by even a difference of 0.2. So as I say, cup CDR is 0.2, someone else will say 0.4. So there's a variance, and that's apparently pretty normal. So here I would have said 0.3, we have said 0.2, and no capping and all other factors held constant, normal disc. Here, on the second panel, CDR of about 0.7, but more importantly for me is that the isn't rule is broken. And up here we can see a bit of thinning in the superior rim. We'll get to that on the next one. Then this one obviously is glaucomatous, CDR of almost 1. Here there's no debate. Maybe the debate would have been here on this patient, which brings me to the isn't rule. The inferior and superior rims of the disc are the thickest, but they are also the most susceptible to glaucomatous damage, and they tend to be the first to be affected when there is glaucoma. So even when we are looking at early glaucoma, patient has IOPs of maybe 25, 26, 27, 28. We've just started getting early glaucoma. What you want to really look out for is notching. Here, look at that, a very obvious notch. I don't know if you can see my arrow. Here, a very obvious notch. It's not a nice round cup. You can see a notch. It is very easy to miss such small details if we're looking through a myopic fundus. Important, again, we dilate and have a good look. Back to my second diagram. This patient has a notch superiorly. And of note is that where the notch is, you start to get parapapillary atrophy around that region, as seen in this patient, and in this patient as well. There's general thinning on that side, but there's also parapapillary atrophy around that patient. About 70% of glaucoma patients have parapapillary atrophy, which is why it is important to also look at and note parapapillary atrophy in glaucoma patients. So we've agreed that the most important thing for us to note is the cap disc ratio. When you get it right, so you must get where the rim exactly is so that we are not measuring plus the parapapillary atrophy. So all these things add up to give you an accurate assessment of the disc. What else is good to add? One, is there an RNFL defect? This is best seen using the red-free light, a dilated fundus. And of note is that because of how the RNFL fibers come towards the disc, the shape of a glaucomatous RNFL defect is wedge-shaped. As you can see here, starting from the disc, it is thin, but it fans out. And that is the area, if you can see with your eye of faith, there's a notch here. Where there's a notch, you expect a RNFL defect, a wedge-shaped RNFL defect, right? Try that next time if you see a notch. Use the red-free light and see if you see darker than the surrounding RNFL region. Most of the time when the patients have advanced glaucoma, they'll tend to have diffuse RNFL defect, and therefore there's not that good contrast that will tell you that there's an RNFL defect. Try and see. Next is, for confirmation purposes, a disc hemorrhage. To be honest, a disc hemorrhage is neither here nor there. It's good to see, easy to miss. Also found in patients with high BP, diabetes as well. So you can easily find hemorrhage. So it's good to find, but not really diagnostic. 10% of glaucoma patients will have disc hemorrhage. That's really low compared to 70% for parapapillary atrophy. This is why it is good to know, but good as an additive. So if it's adjacent to a vessel, as it is here in our patient, just at the rim, so it tends to be at around the area of parapapillary atrophy. It can be up to half disc diameter away from the rim. So if it was here, we'd still consider it as a disc hemorrhage. So,
Dr. Muthee, we can't see your arrow.
oh my goodness. Thank you, Doc. So back to my RNFL. So here is our wedge-shaped defect. best seen using the red-free light. Then disc hemorrhage, very difficult to see. Very difficult to see. I've only ever seen one, and then the patient turned out to not have glaucoma, had high BPs, right? So perhaps I've been missing them. But again, if this one was not in the books, if I was not shown, I probably would have missed this one as well. So we've gone through our 4-3-2-1, 4 things to look at on the outside, the parapapillary atrophy and all that. And inside, we want to look at the rim. Is the isn't rule followed? What is the cap depth? And what is the CDR? CDR being the most important thing we want to look for. And then we want to see, can we see any disc defects with the red free? Is there any RNFL defect? So having gone through those pointers, this patient, these are very easy to, this is an outright CDR of 1.95 because there's still some rim nasally, but this is definitely a glaucomatous disc based on the CDR, right? Very minimal parapapillary atrophy, but there's definitely some temporally. To this side, we also have parapapillary atrophy. When we look at the rim, the superior and temporal rims are intact. Temporal rim is very thin. The other rims look quite okay, but here, so when we talk about cap depth not being the definitive for glaucoma, there are glaucoma patients who have sloping rather than deepening of the cap. It kind of eats away at one side of the rim, and therefore you have a sloping kind of effect rather than a deep excavation. So this patient has that sloping effect, and this patient also has glaucoma. So cap depth is not everything. CDR is more important. Here, very, very large parapapillary atrophy. And not only that, the rim is actually in here. This is not the rim. The rim is in here. So very important to be careful about that. There's a disc hemorrhage. This one is a bit more obvious. Very overall pale retinas. You can see through it. This might be a patient who is an albino. And here there's no glaucoma despite the hemorrhage. Okay. Then this patient to me would be a probable glaucoma because our cap disc ratio will be about 5 or 6. The temporal rim looks pale rather than thin. Here, I would do a visual field depending on whether or not there is a hemifield, not hemifield, or hemianopia. Then I would ask for an MRI or history of, say, does the patient have MS? Because then they tend to get optic neuritis and then recurrent optic neuritis, and that leaves them with pallor, pale discs. I'm hoping all that has made sense, and thank you for your attention, and I welcome any questions. Let us put our heads together. Thank you.
Thank you, everyone. I believe you can start posting your questions on the chat box. If you have any questions, kindly post them in the chat box. I think now we'll welcome Ionic, who are the sponsors for today, to present their presentation as people post, and then we'll discuss the questions after their presentation. Ionic? Okay, Dr. Wanjiku, I think there's a question from Judy. She says, if you don't mind, you might go through notching again.
All right, that I can do. Let me share my slide once again with the pointer. Now is when I'm seeing in the chat box. Can't see the chat when you're presenting. So thank you to the one who said that out loud. Let's do that from the beginning. Here. Is this visible?
Yes.
All right, so we talked about the parapapillary atrophy, that all this is parapapillary atrophy. The actual disc is here. This is the rim of the disc. So very, very important that we differentiate between parapapillary atrophy, particularly in myopes, and where exactly the rim of the disc is. Then this patient, this is an ovoid tilted disc, very much tilted, and all this is parapapillary atrophy. So you can't tell whether or not there's a notch. Very difficult to assess the CDR in this patient. And this is a tough one. These are not an easy one to determine whether or not there's glaucoma, right? So this is one of those where I think you need to refer. So we're asking about okay. Hold on. Okay, so this is the three things that are on the inside of the cup that are very important. The depth of the cup, which you said is not your most accurate assessment of whether or not there's disc pathology, and can be a normal finding, physiological cupping. So not to panic every time we see deep cup, but definitely not to ignore it. The rim, remember there isn't rule that inferior rim is usually the thickest, followed by superior rim, and then nasal, and finally temporal. But because of the nature of glaucoma and the blood supply, the inferior and superior rims are usually the first to get affected. So actually, even when you look at your OCTs, in glaucoma patients, superior and inferior rims are usually the first to be affected. Cup disc ratio, very, very important, and that's the most important factor in determining glaucoma. So in this patient let me get my pointer. I don't know if you're able to see it now.
Yes.
Yes? All right. So in this patient, already the isn't rule is broken. The inferior rim is much, much thinner. Look at where this blood vessel is coming out from. It went all the way in. This is inside the cup and comes out from almost, this is a very thin rim. I was about to say 0.1, but it's not CDR of 0.9. This would still qualify a CDR of 0.8 because the superior rim is still thick, but there's a definite notching at that area. The cup is not nice and round like the shape of the disc itself. There's definitely a notching there. Also of note, where you have notching, you tend to have adjacent parapapillary atrophy. So note that parapapillary atrophy over there. It tells you there's a pathology happening there. If you used a red-free light on this particular patient, you'd see a wedge-shaped defect around that area. So some actually say you should be able to see it even with the normal light. So perhaps this area is darker than the rest of the area. I am not yet there. I still use red-free light to determine whether or not there is a wedge-shaped defect around that area. This is best seen on a dilated examination of the disc. This patient has a normal disc, but this one as well, looking at the isn't rule, is definitely broken here, right? Your superior and inferior rims are supposed to be the thickest. Here, it is not the case. This nasal rim is thicker than the superior rim, and therefore there's a notching there that tells you there's some damage happening in that area, and that could be glaucoma. Parapapillary atrophy happens in about 70% of patients with glaucoma and tends to be adjacent to an area of notching. You find parapapillary atrophy happening in that area. Look at this patient with advanced glaucoma, parapapillary atrophy all around. I hope that answers your question, Judy.
Thank you. I think you've gone through a number of things. We've gotten clarification, I think, with the arrow, which was more visible right now. Dr. Marco has a comment on neuroprotection. She says neuroprotection is now a major area of discussion, especially in patients deteriorating despite low IOP. Maybe you can make a comment on that, and then Dr. Marco can also make a comment.
Actually, I request Dr. Marco to make a comment on that, as well as what is available in our market for that purpose of neuroprotection. Doc, kindly.
Thanks, Dr. Wanjiku. I was not intending to talk, but yeah, neuroprotection now is becoming a major area, a hot topic of discussion, because we know in glaucoma you have mechanical factors and vascular factors all leading to injury of the ganglion cell and ganglion cell layer, and eventually a lot of things are happening in this hostile environment. For example, you have a lot of oxidative stress, a lot of free radicals, down regulation of growth factors, and also apoptosis is increased in patients who have glaucoma. And basically, it's a very hostile environment for these ganglion cells, and all this leads to the changes that we eventually see in glaucoma. A lot of pro-inflammatory cytokines, neurotoxic substances. So what research is now, where the research is going now, because, you know, as you said earlier when you started off, is that you can have a patient with very good IOPs, not going above 10, but they're still progressing despite your treatment. So they're bringing in some medication or some drugs that can help to, for example, decrease this apoptosis, yeah, or decrease the oxidative stresses, or inhibit mitochondrial dysfunction, which happens in glaucoma, or increase basically cell survival. Or, you know, there's so much research going on. At the moment, what we have in our market is brimonidine. Brimonidine is also known as alpha-GAN, and it can be found also in Combigan, which is timolol and brimonidine, or Simbrinza, which is brinzolamide, and brimonidine, or brimonidine itself, which is alpha-GAN. So brimonidine many studies have been done to show that brimonidine actually protects the retinal ganglion cells from somatic and axonal degeneration. So all these things that happen as a result of the ischemia, brimonidine it has been shown to have very significant neuroprotective effects. So does the other one is bitoxolol as well. It has been shown, especially in bitoxolol, it's more of increasing improving the vascular, the ischemic effects of the whole glaucoma process. So it's mostly involved in improving retinal ischemia and vascular dysregulation that comes about from glaucoma. So that's what we have in the market. But you find that that's for the drops. But you find that other drugs like orally, there's citicoline. I think I've seen some centers prescribing citicoline. These are also involved in neuroprotection and have been shown to show some positive effect. And there are many other even Ayurvedic medication like the ginkgo biloba extract. These are some Chinese extracts, omega-3. So usually patients who can afford this kind of medication and have their IOPs well controlled and they're still deteriorating in their visual fields despite treatment, these are oral meds that you can prescribe that have been shown to have some effect in reducing in controlling the degeneration as a result of glaucoma. Another thing I wanted to just mention, like, you are talking about a pale disc and ruling out intracranial tumor. Other things you also have to rule out is from the history, like we had a patient a couple of weeks ago at the dental school, glaucoma clinic, and this patient was sent to us for glaucoma assessment, and he was sent with a diagnosis of normotensive glaucoma, but his beginning IOPs were very low, were like 13 or 12. And on further inquiry, he said he was like in his mid 60s, but you could tell this is somebody who had been taking a lot of alcohol in the past. And when we asked him, he said he only takes beer. But we had to pull the wife aside, and she said he's a constant, he takes kumi and all this illicit stuff for the last 30 years. And that's what was causing his discs to appear pale because of the toxicity from constant and from alcohol intake. So basically, a good history will give you a lot of information. Sorry, one more point. There's a lady also who came with a diagnosis of query glaucoma. And on further inquiry, she had pale discs, yes, and her MRI was normal. But she said whenever she gets pregnant and gets a baby, she goes into PPH. And she's had like 5 pregnancies and 5 situations where she's had to be transfused. So basically, just taking a good history can give you information on why the discs appear to look like they're glaucomatous despite the normal IOPs. So anyway, that's what I had to comment on the neuroprotection. So this is a very big area that there's a lot of research going into it now. Thank you.
Thank you for that, Dr. Marco. And the next question is from Judy, who was also asking about bionating of vessels. Dr. Wanjiku?
Doc, you notice that in both protocols, both the Forge and the GONE protocol, none of them mention laminar dot sign or the bionating of vessels because they're not the most important findings. They probably point towards the cap depth or capping, which is where you say this capping, but they are not part of, they're not one of the most important findings in glaucoma disc assessment. So yes, they're good to know, but as you can see, they're not part of either protocol. Yeah.
Oh, okay. Thank you for that clarification on that. Dr. Masila has a comment. He says, when it comes to vertical disc size, OCT RNFL can give you these parameters. So any comment on that, Dr. Masila? Dr. Wanjiku, sorry. Any comment on that?
OCT is really, really helpful. A good quality OCT gives a lot of information. Yeah. Dr. Masila, you want to unmute and give your comment?
Okay, as we wait on her to, if she has any comment, to get back to us, Prof. Karimurio says, the big question for future researchers is, could glaucoma be a systemic disease causing all these variations in disc involvement? So that is a question for the researchers and something that we can look into. Also, Dr. Masila.
Actually, may I comment on that?
Sure.
There's actually ongoing. So it has been noted that most patients who have glaucoma also have high blood pressure, right? I can count the number of patients that I'm following up who don't have high blood pressure. But one of the questions has been whether the calcium channel blockers that are given or prescribed for management of high blood pressure are part of the problem. So yes, there's research teams looking into whether or not glaucoma is a systemic issue, and I've seen a few papers talking about could it be that we are triggering glaucoma, particularly open angle glaucoma, due to the medications for hypertension. Yeah.
Okay, interesting. Also, another comment by Dr. Masila. She says you can also check where the blood vessel starts to dip into the cup to get an accurate CDR ratio rather than depending on cup paleness. Yeah. And Dr. Onyango says, he's asking, what is the importance of optic disc assessment and RNFL by OCT?
So I think disc assessment was step one, that what do you see with your eyes that then needs to correlate with findings on OCT. But this is a question of privilege, Doc, because you have access to OCT. So for people who don't have access to the OCT, what should they be looking for? On slit lamp examination. So the same things that the OCT will tell you without too much struggle. If it's a good quality OCT, then we should have correlation on fundus exam.
Mm-hmm.
So if you have it, it is good. Then it should tell you. It should actually correlate to what. So first I examine, and then OCT should correlate with what I'm seeing on examination. There's no replacing your examination.
Yeah. Okay. Thank you for that. And there's this optic disc assessment, the OCTs that come where people draw, there's someone who manually draws the circle around the disc. Is that still reliable, or is there that's another topic?
Okay, I've not seen. That would be very interesting. The OCTs have somewhere a quality index. The same way a visual field will give you the percentage of false negatives, the percentage of false positives, and that tells you how reliable that test is. Similarly, an OCT has a quality index, and you want above a 6 out of 10. So it's usually graded out of 10 rather than as a percentage. So you want a 6 and above. We prefer, well, the higher the better. It's like a pass mark. You don't want 60%, you want 80%. This is how reliable the OCT is. So I'm wondering if someone has to manually draw, already I'm questioning. I don't know. I've not seen. I've not seen.
Okay. Yeah. Okay then. Thank you. Thank you for that. Brenda Walaba has a comment. She says inter-eye variation in disc size is important to consider when deciding what the CDR is also. So any comment on that? And Dr. Walaba can also give us a comment. Oh, she says her speaker is letting her down, so she's not able to speak to us. Okay. Any other?
Thank you, Doc. That's a very important point, that the variance, the difference between the two eyes, the CDR should not be greater than 0.2 when you're assessing the two eyes. So that's very important because usually one eye is more advanced than the other. Although you can have glaucoma in one eye only in some cases, if there was trauma, if there was a case of uveitis, if there was it has gone, if there was rubiosis, or so you can have that. But yes, discrepancy between the two eyes of more than 0.2 is a red flag. Equally, a difference in IOP of more than 5 between the two eyes, also a red flag. Yeah.
Okay. Thank you, Dr. Wanjiku, for that great presentation. Personally, I've really learned a lot. Our sponsors today, Ionic, we are welcoming them to present. Ionic, are you ready now?
Oops.
Can you hear me, please?
Yes, we can hear you.
Okay. Can I share my screen, please?
Yes, please.
Okay, thank you. Please, can I go ahead?
Please go ahead.
Yes. Good evening to you all. And once again, I thank OSK for inviting us to join this prestige meeting. And then again, a warm regards from Professor Simon Skeleke. He couldn't make it because the time zones are far different. They are currently at around 2, 3 a.m. in Australia. So I stand in the gap. And then again, thank you for those who have taken the initiative to register with us and currently using Ionic. My name is David Quote, and I work as a commercial director for Africa and Middle East. Again, I've worked with Allergan Pharmaceuticals for 5 years as a medical rep and for 15 years as a country director. So I've been traveling into Kenya more times, and therefore I had the opportunity to meet some of the doctors. And again, in some of the international conferences we meet. I thank you all for your support as I roll up this presentation. So this is Professor Simon Skeleke. He is a glaucoma specialist. He was just the past president of the Ophthalmological Society of Australia and New Zealand. He's a lecturer and then owned 2 eye clinics. He's an associate professor also of the University of Melbourne. So we can see the 2 images clearly. This is what you must be educating me on, not the other way around, so I'll skip it. This is studies which was done by TAM-YC, Global Prevalence of Glaucoma and Projections of Glaucoma Burden through 2040. And you could clearly see that the graph keeps on going upwards. Lack of detection rates and other studies done, and you could see the figures are not too good. What is wrong with the current machine that we have? There is absolutely nothing wrong with the machine. The machine is good. We've been trained with the machine. We use the machine. The machine gives us good results. But Ionic is saying that you need a lot more money to invest into this machine. And this machine is labor intensive. It causes a lot of stress for patients when confined in one area and also add some darkness to them, claustrophobic. It's a clinic base and therefore will not be able to move this machine to do outreaches, to do screenings. It also occupies a large space in our hospitals. And because of the factors above, we don't have this machine common in the other areas. Ionic is any computer be in a laptop, a desktop, or a tablet. It is very cheap, very accessible, and it's also patient-friendly. And finally, you can do Ionic at anywhere and at any place. The reason is you just need to create an account with us, just like a DSTV or a Netflix. Once you have an account, you can log in at anywhere and at any time to allow your patient to do as many tests as you want. So if you want to register yourself, which a lot more people have done, and they link me and then I activate the account for them, you just go to www.ionic.com and then you click on registration and then you register. After registration, you can link me and then I can just activate the account for you so that you can also have a month free trial without any commitments. We don't need any Visa card commitments. We don't need any money. We just activate it for you because we believe in our products. Just to use it for 1 month to try on your patients. And then from there, we can pick it up. All those people who have tried this are happy to continue with Ionic. It's very usable, very accessible, and very affordable. So this is a clear sample of Ionic test results. And if you look at the top right of the screen, you could see the parameters. They are all available to do the interpretation of the results. On the left side, Ionic does 24-2. We zoom into the macula 10-2. We do wide field 30-2. And then we also added driver licensing tests as well as pilot licensing tests for both the Air Force or the pilots and then the navigators. So we are saying that you can do Ionic at anywhere and at any time. With Ionic, the doctor has total control over patient data because we don't allow any patient to get close into the system. The only time the patient gets access is when the doctor gives the patient access. So no patient will be able to register with us. And that's why we ask of ID card and then the medical numbers to do verification to ensure it's only for the clinicians. It integrates the clinic and is very cheap. You will agree with me. It improves your clinic flow and it can be done at anywhere and at any time. But the most interesting thing is the test is very enjoyable when the patient is doing the test. You just look at the gold star. When you see the target, then you click the space bar or the mouse. So this is all that I'm talking about. So during the test, this is the interface that the patient will see. You look at A, you see a spinning gold star. So that's what the patient needs to focus on all the time and throughout the test. And below it is the test progression bar. So you get to know how far the patient has traversed with the test. And then when we come to B, you could see some target flickering. These targets are the target when the patient sees, then the patient clicks the space bar. Or if you are using the mouse, the patient click on the mouse. That's all the patient needs to do. Fixate on the gold star, and when the patient sees the target, the patient click the space bar or the mouse. You don't need to worry about the particular angle that the patient needs to sit because we configure in such a way that when you sit in front of the machine quickly adjusts. Perhaps if you are too far from the machine tells you that you should come a bit closer and then the vice versa. So the moving fixation start at the top corner, lower right testing, and then start moves to each corner, testing each quadrant at a time. Before the test starts, the blind spots will be detected. And that's where when you are not properly seated, the machine will be able to speak to you either to come front a bit or to go back a bit. And then again, we are saying that you don't need to buy specialized cameras or even any cameras in addition to your desktop, in addition to your laptop, in addition to your tablets. The inbuilt webcams that comes with the machine are accurate to run the test. We have improved upon the test algorithm, and therefore it's faster than the machine-based. 3 minutes normal, 5 minutes glaucoma. The screen calibration is automatic based on the initial responses, and then also the decibels adjust accordingly. So this is when the person is about to do the test. This is the interface that you see. So it tells you the distance that you sit at averagely at an arm length, and then you fixate on the gold star, and then once you see the target, then you click. So the patient is doing the test, fixate on the gold star. Currently, the system is trying to find the blind spot. Once the blind spot is found, you see that a blue ink is generated below the star. The star changes color when you are out of reach whilst you are doing the test, and the system speaks to you to adjust appropriately. So a lot more people ask, which of these gadgets should I use? So each and every one, and then the advantage. So if you want portability, we are saying that then you have to use the tablets. If the screen size, we know most of the time, the desktops have bigger screen size. Stability, desktop, and then also the laptop. And the laptop, you can even tilt the laptop. And the inbuilt cameras are mostly always, it comes with the tablets, and then the most laptops that we have currently all have inbuilt cameras, and even with the desktop. We're saying that with the licensing test and then the pilot test, you can run on both the laptop and then the desktop, but it cannot be run on the tablet. The tablet, you can only do the visual field test. So this is a patient doing the test. One eye closed, we test one eye at a time. This patient fixates on the star, and when the gold star comes, he just clicks on the target that he sees. So that's how the test is run. Very friendly, user-friendly. You can see that the patient is enjoying the test. And then you can see that the background, it's very lit. So what we are saying, the light should not shine directly onto the screen or onto the eyes of the patient. Once these things are not in place, you get accurate results. You can choose to darken the place a bit, or you can choose to completely darken the place. Any of the under the lights or in the dark. So we have run this extensive a lot of studies. These studies were published in Asia Pacific Journal in Philadelphia in 2023. And on the left side, you see the ionic maps, and then on the right side, you see the standard machine. So in terms of normal vision, early glaucoma, and then moderate glaucoma, you can see that the diagrams are almost the same. Further into the right side, the area under the curve, you could see that even ionic is doing better than the OCT. What we are saying is there's no significant difference between the test accuracy of ionic and then the standard machine or the gold standard machine. We've done studies as against patients using the ionic as against the machine, and 84% are saying that ionic is the way to go. A lot more people had opportunity to ask about these repeatability tests. Yes, when you do the test, after 3 eyes, the system itself will generate a progression chart for you so that you'll be able to do your analysis. So this is a study which was done in Vietnam, and is comparing the correlation for mean defects and then the correlation for visual field index. And you could see that the diagrams and then the values are similar of ionic as against our visual machine.
Mr. David, kindly wind up.
Okay, all right. So we have done studies at clinics as against the home, And therefore, the values are the same. So the accuracy is the same. So you don't need to bother when you are sending a link to the patient or doing it at the clinic. We have done a lot of projects, that is here, and then we've been able to compare DICS with the visual field test. We've done some with the OCTs, which is here. You could see the OCT as against the visual field test, and you could see that the defects points are almost the same. We have done a lot more. This is another OCT as against the ionic. We have done all of these things. And then there are more of this is the driver licensing test. We've done studies on ionic as against the machine base. And you could see that the points are the same. So same, we have more samples here. And then this is again the repeatability test to get your progression analysis. So I would like to end here. And then again, if you have opportunity, you can visit www.ionic.com for a free trial. You register and then we activate the account for you. I will share my details on the chat. I thank you once again and we'll continue to partner with OSK. Currently, we are looking for a distributor in Kenya. Once we get it, we localize Ionic. Thank you very much for the opportunity once again.
Thank you, Ionic, our sponsors for today, for that presentation. Thank you, Dr. Wanjiku. Thank you, Dr. Walaba. And we thank you all for joining us for our CME today. We are encouraging you to send your papers to the Kenya Eye Health Journal. I think submission is still ongoing. So if you have a paper, you can present it. You can send it to them for publishing. And otherwise, thank you. We'll end here and wish you a good evening. Good night. You can leave. You're free to leave.